Rcog Cervical Cerclage Guidelines 2022. History indicated cerclage is applied when single-term pregnancy with history of previous 3 or more preterm birth and so serial sonographic surveillance is done in the presence of history of 1 or more spontaneous second trimester loss or preterm birth and no history of cerclage. And in the benefit of ultrasound is if the cervical length is 25 or less than 25 millimeter, then we will go for ultrasound indicated cerclage, and if length is greater than 25 millimeter, then there is low risk of loss or preterm birth. What if we incidentally identify short cervix? For example, we did the examination due to the presence of any pain or discharge, and if no risk factor preterm birth, then we will not apply any cerclage. And if history of previously unsuccessful transvaginal cerclage or excessive cervical surgery history, then we will discuss and consider transabdominal cerclage. And emergency cerclage delays birth by 34 days, and it reduced 2 by 4th in preterm birth, especially before 34 weeks. What is cerclage? Prophylactic intervention in care of women at risk of preterm birth or second trimester loss. When first time cerclage was done in 1902. What is the benefit of cerclage? It provides structural support, maintains cervical length, and mechanical barrier to ascending infection. What were the previous terminologies used for the cerclage? Prophylactic, planned, emergency, urgent, or rescue cerclage. Indicated cerclage applied and at what gestation? Prophylactic measure in asymptomatic women at 11 to 14 week, and when sonographic cervical assessment done and at which gestation? We do TVS with empty bladder at 14 to 24 weeks. And what are the prerequisites of ultrasound indicated cerclage? Asymptomatic woman and with no exposed fetal membranes in vagina. What is the emergency or rescue cerclage and when it is applied? Premature cervical dilatation and exposed fetal membranes in vagina, then we will apply rescue cerclage. When emergency cerclage need arise, for example, we are doing ultrasound examination and cervical length is short, or due to any symptom like discharge, bleeding, pressure, we do per speculum examination and need for emergency cerclage arise. And what is the time or gestation up to until when emergency cerclage can be done? Up to 27 plus 6 week gestation. What are the different types of cerclage? Transvaginal or McDonald. It's a per string suture at cervicoisthmus junction without bladder mobilization. And what is the Rcog? It is a high transvaginal cerclage or purse string suture above level of cardinal ligament following bladder mobilization. What is the transabdominal cerclage? Suture at cervicoisthmus junction via laparotomy or laparoscopy. What is the occlusion cerclage? Occlusion of external os by non-absorbable suture. Its benefit is retention of the mucus plug. It is unhelpful if previous adverse events are helpful for history indicated cerclage. For example, painless dilatation or rupture of membranes or prior cervical surgery, and we have no time for ultrasound indicated cerclage. Now, incidence in the case of cerclage and no cerclage, if cerclage is applied, then history and with the history of previous 3 or more preterm birth or second trimester loss, then in the case of cerclage applied, 15% incidence of preterm birth before 33 weeks. And if no cerclage applied, then 32% incidence before 33 week. Similarly, if history of previous 1 preterm birth before 33 week, then there is no significant difference. In the presence of cerclage, the incidence will 14%, and with no cerclage, with only expected management, incidence will 17%. But in the history of 2 preterm birth before 33 weeks, with cerclage, incidence is 12%, and with no cerclage, incidence is 14%. No benefit for history indicated cerclage with the history of previous cervical surgery or uterine abnormalities. Now, I'm going to share a result of a study in which Shirodkar difference in the incidence with Shirodkar and with expectant management. With Shirodkar, preterm birth before 33 weeks incidence was 22% and with expectant management was 26%. And there was no significant difference in perinatal morbidity or mortality. And if we incidentally identify short cervix, if we incidentally identify cervix less than 25 millimeter on the late second trimester scan or anomaly scan with no other risk factor for preterm birth, then there is no benefit of cerclage. What if funneling is present? What is a funneling? Funneling is the dilatation of internal os on ultrasound. No need for cerclage if cervix is not 25 millimeter or less than 25 millimeter. Regarding Bergella meta-analysis, in the presence of history indicated cerclage, incidence of preterm birth before 37 week was 31%, and history indicated cerclage it was 32%, and incidence before 34 week with ultrasound indicated cerclage was 17%, while with history indicated cerclage was 23%, and similarly perinatal mortality with ultrasound indicated cerclage was 5%, and with history indicated cerclage was 3%. Now, ultrasound surveillance of women at high risk include all these women at high risk. For example, with previous preterm birth or second trimester loss, 16 to 34 week gestation, previous pre-prom less than 34 week, previous use of cerclage, non-uterine variant, intrauterine adhesions, or history of trachelectomy. What we will recommend to above high risk women, we will recommend them reviewed by preterm prevention specialist by 12 weeks or with dating scan, and after secondary screening test TVS cervix every 2 to 4 weeks between 16 and 24 weeks. 16 to 24 weeks. Women at intermediate risk are a history of previous C-section at full dilatation or let's and with the depth of greater than 1 centimeter or 10 millimeter or more than one procedure or cone biopsy. Recommendation for intermediate risk women are TVS cervix no later than 18 to 22 weeks as a minimum. Cervical screening may be considered or may be uncertain when on serial screening cervix is short but no history of preterm birth. No need for history indicated or ultrasound indicated cerclage in multiple pregnancies. Role of history or ultrasound indicated cerclage is uncertain when Mullerian anomalies, previous cervical surgery, obstructive procedure, for example laser or diathermy, or multiple DNC who display no additional risk factor. In the case of local excision depth, if the excision depth was 10 to 12 millimeter or less than 10 to 12 millimeter, then incidence of preterm birth was 7.1%, and in the general population it was 3.2%. And similarly, if the excision depth was 10 to 12 or greater than 10 to 12 millimeter, then incidence was 9.8% preterm birth, and in general population 3.4%. And with the excision depth of 15 to 17 millimeter or greater, preterm birth was 10.1%, and in general population 3.4%. And if excision depth was 20 millimeter or greater, then incidence was 10.2%, and in general population 3.4%. Now, what is the relation of cerclage and BMI? Cerclage is effective when BMI increase. In non-cerclage group, with increased BMI, it is inversely proportional to the gestational age at birth. When transabdominal cerclage is performed, it can be performed preconceptually or in early pregnancy, and more effective when performed preconceptually because it's not associated with subfertility, technically easy, and lower anesthetic and fetal risk. As higher cerclage is applied, there will be low risk of preterm birth. Laparoscopically, abdominal cerclage is same efficacy as to abdominal cerclage with laparotomy, but with fewer complications. Now, the result of a study in which laparotomy group and laparoscopy group was compared, then the incidence of preterm birth then the incidence of third trimester birth was 100% in the laparotomy group and 97 to 100% in laparoscopy group. Fetal surveillance was 100% in laparotomy and 98% in laparoscopy group. Complications were higher with laparotomy group 22% and 2% in laparoscopy group. And second trimester loss was 7.8 in laparotomy group and 8.1% in laparoscopy group. And birth after 34 weeks was 84% in laparotomy group and 78% in laparoscopy group. And there was no case in which conversion to laparotomy in laparoscopy group was done. Delayed miscarriage or fetal death with abdominal cerclage in situ, then up to 18-week gestation ENC or DNC can be performed, or you can cut suture via posterior colpotomy, and if it's failed then maybe hysterotomy or section required. High chance of cerclage failure when there will be high chance of cerclage failure if cervical dilatation greater than 4 cm or membranes prolapse beyond external os. Cerclage with cerclage birth at all preterm gestation will reduced except less than 24 weeks. Insertion of emergency cerclage highly likely to result preterm birth before 28 weeks. What are the contraindications to cerclage insertion? If active preterm labor, clinical evidence of chorioamnionitis, continuing vaginal bleeding, pre-prom fetal death, evidence of fetal compromise, or lethal fetal defect. Regarding female counseling or information before cerclage insertion is verbal and written information about potential complication. For example, risk of intra-bladder damage, cervical trauma, membranes rupture, bleeding during insertion, cervical trauma or laceration with spontaneous labor with cerclage in situ, and anesthesia requirement for removal of higher cerclage. For women undergoing non-emergency cerclage, there will no increased risk of pre-prom or chorioamnionitis, induction of labor, section, preterm birth, second trimester loss, or cervical trauma if labor will start. And pre-op management before cerclage is dating scan, aneuploidy screening before history indicated cerclage, insertion to ensure viability, singleton pregnancy absent, lethal or major fetal anomaly. Before ultrasound indicated or emergency cerclage, anomaly scan should present. Before emergency cerclage, maternal WBC, CRP to detect chorioamnionitis if clinical signs present, but if not, then go for cerclage. If CRP is less than 4 milligram per deciliter and WBC less than 14,000, then you can prolong pregnancy. Amniocentesis before emergency or rescue cerclage or ultrasound indicated cerclage is insufficient evidence is present regarding routine amniocentesis, but in selected cases, for example with suspicion of intraamniotic infection, amniocentesis does not appear to increase preterm birth before 28 weeks, but likely some risk present from this procedure. And incidence of intraamniotic infection is with ultrasound indicated cerclage is 1 to 2%, and rates of intraamniotic infection vary from 13 to 51%. Amnio reduction before emergency cerclage recommended or not? There is absence of data to refute or support, so this should not be recommended or carried out. A latency period we observe between presentation and cerclage insertion. No studies to support immediate versus delayed cerclage insertion, either rescue or ultrasound indicated procedure. What about routine genital tract screening before cerclage insertion? Not routine needed, but in the presence of positive genital swab culture, antimicrobial therapy on individual basis after discussing with the microbiology team should be given. What is a perioperative tocolysis for cerclage insertion? Not routinely used, but based on individual cases. Should prophylactic or perioperative antibiotic be given? Should be at the insertion of the operating team. Anesthesia method for cerclage insertion, both G and regional can be given and are safe, but dependent upon the team and the woman about the choice. Regarding GA, short recovery time but higher demand of opioid and non-opioid analgesia present. And cerclage can be performed as a day case procedure. And what is the technique and material for cerclage? Non-absorbable suture, place as high as practically possible. No difference in using two or single purse string suture. Cervical occlusion suture in addition to primary cerclage is not recommended. In a study of preterm birth, less than 33 week, it was experienced that with the double cerclage group, there was no preterm birth, but with the single cerclage group, 5 preterm birth were noticed. Bed rest is not routinely recommended. Similarly, sexual intercourse, abstinence following cerclage not routinely recommended. Role of post-cerclage serial sonographic cervical and surveillance is also not routinely recommended. And in the presence of history indicated cerclage, additional ultrasound indicated cerclage is also not routinely recommended, but it may be associated with the increased pregnancy loss and preterm birth before 35 week. Emergency cerclage following elective or ultrasound indicated cerclage, it's also based on individual basis. Fetal fibrinogen testing using following cerclage insertion, routinely it's not recommended, but we can do for reassurance because it's a high negative predictive value for subsequent birth at less than 30 weeks in asymptomatic high risk women. Now here a Benson study in which labor at 23 to 34 week post cerclage insertion, and effect of fetal fibronectin testing was sensitivity 100% and the specificity 78%. Positive predictive value in 2 weeks was 28% and negative predictive was 100%. What is the role of progesterone following cerclage? Routinely not recommended. No evidence either progesterone or Arabian pessary alone are more or less effective than cerclage. Both progesterone and cerclage were equally effective for preventing preterm birth. When cerclage should be removed, transvaginal should remove before labor at 36 plus 1 to 37 plus 0 week unless birth by a pre-labor C-section, or if established preterm labor, then remove the cerclage. For high or chirurgical cerclage, anesthesia required for removal, and in case of abdominal cerclage, birth by C-section and left cerclage in place following the birth. Now, should cerclage remove following preprom? If preprom at 24 to 34 week, you can delay it for 48 hours in order to facilitate in utero transfer steroid cover. But if preprom before 23 week or after 34 weeks, there is no benefit to of latency or delaying for 48 hours.